Yes. So when we're talking about cardiovascular exam, the surface anatomy matters because it is like giving you a map. It's like your map, not just for the auscultation, but also your EKG leads. And we're going to have a session only for EKG, how to place them, how to interpret them. And I would like to decomplicate it. Okay. When you look at someone's chest, I want you to feel like you have Superman X-ray vision. What I mean by that is when you see them, you see through them. Let's say, for example, لا قدر الله, you see someone and that person has been stabbed. If they've been stabbed in the chest, it depends where that's going to land. If they've been stabbed in the chest, and this is unfortunate, but it's not like unlikely for you to see it because you're going to be working in the emergency room um or even something happened. For example, this guy has been stabbed in the chest. You can see that the blade is going behind the sternum, right in the middle. So the next question is, what chamber of the heart is lying behind the sternum? Who can tell me that? طيب سمعوني إخواني وأخواتي. أنا هدول شغلات أنا عارفهم. I am here لشان أنتوا تتعلموا. وما في تعليم بيكون when we are comfortable مرتاحين. لو you are uncomfortable, that's where it sticks in your mind. We complain that we go into traditional classes and the teacher just wags the finger at us, just gives us something, and we go and we have to learn and we have to regurgitate عن ظهر قلب. But then when we have the opportunity to interact, we feel like we need to go back in the room, or I don't want to feel like I'm embarrassing myself, or everybody رفقاتي watching me. It doesn't matter. This is your learning environment. You're gonna make mistakes. I hope you make mistakes. This is where to make mistakes. But come out of your comfort zone because you will not learn nothing there. And you'll make me understand you better so I can design these things better. I was going to make you a game today, but I realized I don't know any of you. I don't know what you like, what you dislikes. I don't know what your learning style is. I don't know what makes you, happy, what makes you laugh, what makes you angry, what makes you what kind of experiences you had with other teachers. So if you interact with me, I promise you, only you will benefit. بس I already know these things. So لو سمحتم, interact with me. It will only benefit you. طيب, there, right atrium, the arch of the aorta. Why am I asking that question? I am asking that question because when we imagine the heart, how it is when we are in medical school before we see somebody, we think just the heart like this, left, right, great. But the heart is not like that. That is a heart that is written on a piece of paper. The heart is actually twisted over a vertical axis. Okay. So if you see the heart, here it is, the first thing that you see is literally the right ventricle because the left ventricle is on the other side. And behind it, the aorta is also protected by the right atrium. Even when we want to give you a heart that is shaped perfectly, colored and everything, you can see that the right ventricle is here, but you can see the left ventricle here. This is not how the heart is. The heart is twisted, slightly rotated. That's what we call the heart axis. Okay? And then you can see if I was to put a line between the heart tip and the heart top, we think about it as if it's holding like this, but it's not. It's literally diagonal. So it's diagonal and it's twisted. That's what we call the heart axis. Does this make sense, everybody? Give me reactions, give me whatever you want. Please. It's my 5 o'clock and I'm acting like I'm the one who has 3 p.m. There you go. Thank you. If you understand this, many of the problems that you have, thank you, Leyan, thank you. Many of the problems that you have will start to make sense. I'm sorry, you are in an era where you have to learn these things by yourself. You will not always have someone to direct you. And اللي متوسم بالخير منكم إنه you have this desire to be the best you can be despite the obstacles. And that's admirable. So I'm here to help you. I can't be there with you, but I can give you, instead of giving you a fish, I want to teach you how to fish. So لما تروحوا and you have a patient in front of you and you took the stethoscope and you put it there and you say, I don't know what I'm supposed to do. I don't know if this is normal and if this is not normal. It's okay. Just leave that panic behind. Close your eyes. Take a deep breath in. Exhale. Crack a few jokes with the patient to make them feel comfortable so you don't feel their pressure on you. And then put that stethoscope there and say, where am I putting the stethoscope? Right by the sternum. Okay, I remember that the heart is not supposed to be like that. So the sternum is not a midline, and the right side of the heart is it to the right and the left side is to the left. That's not how nature has written it. The sternum is here. Behind it is the left ventricle. So the left atrium and left ventricle is behind. Okay, so how do I listen much better to the left atrium and the left ventricle? Well, can I bring the left atrium and ventricle closer to the sternum? Maybe I can do that. Do you think I can do that? How can I do that, you guys? So if I have a patient sitting and I'm listening here, I'm just listening to the right heart. How do I listen to the left heart, which is behind?
I think it's from the back or by leaning forward.
Muhammad, by leaning forward. So the heart is like a chandelier, and the chandelier is hosted from the ceiling. So if you move it closer to the front, then yes, you can bring it closer to the front in order for you to listen to it. Good job. What else can you do, Muhammad?
Maybe by listening at the lateral aspect of the chest.
Okay. What
Like,
else?
what else can say? Actually, I don't know. Just this.
Keep thinking, keep thinking, keep thinking. I'm not asking you to recall something from a book. I'm asking you if you are Sir William Osler and you are that philosopher, because we all just marvel at how could they think of such things, but we never really walk the path that they walked. And the path is simple. I just want to ask myself, I wonder. طيب هاي نصيحة إلكم. my practice تغير إلي لما my mentor قال لي واحد اليوم, did you know that there is something that kills your brain from thinking? I said, really? What is it? It's something you say all the time. And I started to say, I don't know. And he says, exactly. I said, oh, are you saying that by saying I don't know, I'm killing my thinking? He says, well, think about it. You're sending the message to your brain that you've given up. So instead of saying I don't know, say maybe it is, and leave it open. Your brain stays open, and sometimes you go to sleep, and at 3 a.m. you wake up and you're like, oh my God, yes. Has that happened to you before, guys? Sometimes it does happen. You wake up in the middle of the night and something you've been thinking about, you find out that, yeah. So uh, then we have Sarah بتقلنا, maybe by listening to the sounds of the arteries or veins that arise from the heart left. So what you're saying is not only move the person to the front, but position your stethoscope on the left of the sternum. Good, good. Well, let me share with you something. Your heart moves, does it not?
Yes, exactly.
When it contracts and then it lets go. What if it contracts, but when it lets go and it's filling with blood, you asked your patient to exhale. If they exhale, their chest size becomes smaller. And if you ask them to move forward, that smaller comes closer to the sternum. So you move it to the sternum, and the chest is smaller, so you have a smaller room where the echo would be, and you can listen to it much better. So some of these sounds, you hear them at expiration. Does this make sense?
Yeah, that's
Another
right.
thing you can do is you don't have to have the patient always sitting. What happens when someone leans on their left? When they lay down on their left, well, the chandelier that was in the middle now comes closer. And then if you do lean on the left side becomes smaller. And then lean forward, the heart comes closer. And then at exhalation, the rib cage becomes smaller. And now you can listen to the murmurs much better because it's close to the chest. And you moved the heart from behind the sternum. So you took away the bone buffering of the sound. Does this make sense? So when we have surface anatomy matters, it's because you can use it as your Google Maps. If you hear something in a specific area, then you try to imagine where that area is. Is it the apex? Is it the septum? Is it the right ventricle? Is it the right atrium? Is it the left atrium? A lot of the students say, I can't visualize where the heart actually sits. It all feels disconnected. Do you guys feel like this? I hope that I have given you a bit of a three-dimensional visualization for you to know where the heart sits. Yes? I really do need the reactions or text to know that I'm going the right way. Perfect. Thank you. Yep. I need as many reactions as possible.
Yes, now it's
Bedside,
better.
beautiful. Thank you.
Thank you, doctor.
Now, if you have an echocardiogram and it's delayed, you can actually, what can you see? Sometimes when the heart is sitting with the patient up front and you see that the apex, which is the tip of the heart, whenever it punches, it pumps, it somehow hits the front rib cage. It should hit the front rib cage slightly to the left. If you put your arm, if you put your arm here, unfortunately, if it's all the way to below the nipple, then that means the heart had a movement. And if that's where it sits, that means the heart now is larger than it should because the apex, the apical point of maximum impact, PMI, is displaced. And you have to say, is it displaced to the right or is it displaced to the left? If it's displaced to the left, then it's probably because the left ventricle, which is posterior.
Enlarge, enlargement of the left ventricle.
تفضل.
I said that maybe left ventricular hypertrophy.
Either left ventricular hypertrophy or left ventricular dilatation. Both of them increase the size of the left ventricle. One with muscle, the other one with liquid. فهمت علي?
Yes, yes, okay.
Because they grow, the point of maximal impact is actually off to the side. What if the point of maximal impact was not displaced to the left, it was actually displaced to the right? Wow. Why would that be? If the right ventricle is bigger. Now you're talking about right ventricle failure, right ventricle dilatation. مفهوم؟
Yes,
طيب
yes, okay.
أذكركم basic anatomy and physiology. تتذكروا إنه في 2 circulations. الأولى اللي بنعرفها systemic circulation. It's the left ventricle pumping blood into the aorta, pumping blood to the rest of the body. بس في smaller circulation. تتذكروها؟
Pulmonary circulation
الpulmonary circulation. بس هالpulmonary circulation connected to what?
to the lung,
And on the other side connected to what?
right atrium, lung, and the left atrium.
The right ventricle.
Right
So the
ventricle,
right
yes.
ventricle
Sorry, sorry.
is pumping blood to the circulation of the lung. طب شو اللي يحصل لو عنا blood clots in the lung? There is an obstacle and the right ventricle now have to work harder. You have right ventricular hypertension. ولا شو اللي يحصل لو عندك emphysema ولا scar tissue in the lung? The pressure goes up. Now you have traffic in the circulation, and the right ventricle is trying to pump harder every single beat for days, weeks, and months in order to send the right amount of circulation. eventually, like a muscle, like you go to the gym and you do this, your muscles start to grow big. You have right ventricular hypertrophy. So that will give you the point of maximal impulse will be shifted to the right, not the left.
Yes,
Are we
but
good?
I want to ask if we can say any pulmonary hypertension leads to right ventricular hypertrophy or no?
We can say it. Can repeat your question again.
Pulmonary hypertension, when it
Uh-huh.
increase, we can it will lead to right ventricular hypertrophy. Is that okay?
Yes, that is correct.
Okay, okay.
That is correct. And to be complete, I will tell you that pulmonary hypertension follows a trajectory. Okay, so it follows then and the trajectory is as follow. We are excellent at understanding the left ventricle. We are not that good at understanding the right ventricle. And the right ventricle, when it starts to pump against a problem, the right ventricle, when it starts to pump against the problem, here is the sequence of events. We call it compensation, then decompensation, and then failure. I put it in the chat and I will share it on video. So if you look at a pulmonary hypertension and what it does, pulmonary vessels narrowing leads to increased vascular load. So it just increases the pressure in the right ventricle. How does the right ventricle adapt? It increases the muscle contractility and the wall thickness. It starts to become thicker and it starts to become bigger. As it does, to maintain the cardiac output, the right ventricle dilates and the heart rate increase in order for the cardiac output to remain. If pulmonary hypertension persists over time, this is only temporary compensation mechanism. Eventually, what you see is the left ventricle, which usually in order for it to contract, it contracts against what? It contracts against what we call the septum, the interventricular septum, right? It's almost like you are going to throw a rock at a distance. In order for you to throw a rock at a distance, you bend your knees and you use the ground as the platform upon which you build the strength to throw it further. Yes? That ground that you use to throw the rock is the septum for the left ventricle. It's usually just his because the right ventricle is just sitting there. There's not much pressure unless you have a pressure building up in the right. And now the right ventricle starts to adapt to work harder. And when it works harder, it starts to steal the septum from the left. And then you start to have dysfunction. We call that uncoupling. And then you start to have right ventricular failure. Does this make sense?
All good, doctor.
Excellent, excellent. So now we are going to continue with the other thing that we're going to do in our physical examination. Many of your colleagues also mentioned that they feel that in order for you to examine the point of maximal impact, بعض منكم بيستحيي، بعض منكم they can't touch the patients yet، بعض منكم feel like they it just feels uncomfortable putting your hand on a patient, especially as it comes to places that are private. It wasn't easy for me as a medical student to learn that. بس تعلمت something very interesting. If I announce what I do, it becomes better for me. شو معناتها؟ ست الكل، لو سمحتي، أنا الدكتور حسن اجت لعندك، قالوا لي إنه محتاجة مساعدة. What happened to you? How did you happen? الله يكون معكي. Must be very difficult. Tell me more. And this happened before or just yesterday? لو تسمحي لي ممكن I had a misunderstanding. أولا سمعت منك مش قلتي لي، سمعت منك البارح وبعدين بتقولي لي 3 أيام. Is it 3 أيام ولا امبارح؟ طيب. وبعدين you get the information and then you say, so here's what's going to happen next. أول شغلة, I'm going to wash my hands. I'm going to come back here. When I come back here, you are going to allow me, لو سمحتي, to examine you. I'm going to start with the right that doesn't hurt you. And then I'm going to go to the left. I know it hurts you, but I'll be very careful. When I do that, I'm sorry, but I'm going to have to uncover that area, and that means your breast. I'm going to close the window. Is there anything that I can do to make you feel more comfortable and in private? No? Thank you. Okay. I'm going to ask you, can you lift your shirt for me? And let her lift her shirt. And then you can say, my hands tend sometimes to be um, cold. I'm going to put them on your hand first so you'll see how cold I am. Then I'm going to move them to below your breast. And then I'm going to move them to your breast. Okay. Is it okay if I examine your breast quadrant by quadrant? Okay, I'm going to start here and I'm going to move here. You continue talking. You don't go quiet. And all that makes you feel closer to her, makes her feel that she can trust you because she anticipates what you're going to do. You never know the trauma that the other person must have gone through. It does not matter if they are laughing, if they seem happy, if they seem comfortable. Sometimes all it takes is a word, a smell, a touch for a trigger. Okay? Any questions? This is a very, 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 very important moment. Very important moment. لما اجت من المغرب على أمريكا كان لازم أغير the way I approach things لأن things in Morocco are not the same here. For example, تعلمت إنه if I'm going to examine anyone in their private area, I have to have somebody else there just for a moment so that there's a witness. It did not matter if it was a man or a woman. I needed to have somebody in order to do that. I needed to announce what I'm doing. And while I'm doing that, I did not forget to be compassionate. And I was going to do, here's what I'm going to do. Here's what I'm going to do. And there were days where no matter what, it just made me uncomfortable. Guess what? That uncomfortable feeling loses power over you once you say it. Forgive me, Mrs. Smith. I am a little bit nervous. This is my first time in a long time I'm examining a patient. I was taking my boards until now, and I just got back to the bedside. So if I do anything that's off, please understand that it's probably me being uncomfortable and feel free to correct me. Does this make sense? You appeal to their caregiving sense and you show them innocence. And that goes very smoothly by then. Okay. Then when we talk about the chest has a system. Whenever you are in that system, what are the bars in that system? The blue are the ribs. The yellow is costal cartilage. And then you have the sternum. And the sternum is like a tower, but leaning. The top of the tower, the manubrium of the sternum right here, is actually leaning forward. So we start to call these things by names. We have the sternal angle. We have the mid-clavicular line. This is the clavicle. The mid-clavicular line comes through here. You have the fifth intercostal space. Okay, so this is how we speak to where's that landmark. You say on the intersection of the mid-clavicular line or the mid-axillary line, if it is off to the side underneath the armpit, mid-clavicular line on the right at the fifth intercostal space, proximal to the sternum. That's how we speak. Does this make sense, you guys? Excellent. And we talked about this is not a pyramid. This is a tilted, twisted pyramid. The right ventricle sits most anteriorly and directly against the sternum. The left ventricle forms the apex and project left and downward. The atria are positions at the base of the pyramid and they are resting against the spine. So if you have a stab wound by a long thing in the back, it hits the atria. And then the tilt explains why the apex is found left of the midline. What is an APTM? That is where you're going to put your auscultation points. The A is aortic. The aortic valve can be seen in the right second intercostal space, which means it's going to be to the right of the sternum, proximal to the sternum, at the right second intercostal space. Why do we have these complicated? Because they are precise. And if there is a blind, if there is a blind physician, you're speaking to them, they can visualize just by your words the precise location where you're pointing to. P is the pulmonary. It's the left second intercostal space across from the other one. Then you have T is the tricuspid. It's the left fourth and fifth intercostal space. And then the M is mitral. It's the fifth intercostal space at the apex. Okay? First, we do a palpation. You can start by the patient laying down. If you think about the heart as a chandelier hoisted from the neck and dangling inside the chest, if you put the patient on their back, then the heart will go backwards farther. But it's not too far. It's not like it's taking 2 miles trip. It's just there, but it's slightly. So you go into the mid-clavicular line, here it is, and you start to look for the apical beats. Now, this guy does it with their fingers, as if he's taking the pulse. I will tell you, I don't do it that way. I do it with the palm of my hand, and I put the entire palm of my hand just like this, because that is a surface area of my hand, and then I'm going to feel it somewhere. And when I feel it, then I move it so that it hits here. I kind of move my hand, and when I move it and I finally hit it, then I see how far is it. Is it present? Is it displaced laterally and inferiorly? And is it a normal tap or is it a forceful heave? When you auscultate that lub dub, lub dub, lub dub, lub dub. But most people don't tell you that there's lub dub. There is an actual gap between p, 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 p. There is a small gap, and you have to see that gap. It's not going to be no, it's not one after the other. There is a gap. Okay? So there is a S1, S2, and a diastolic gap. You put the diaphragm or the bell. If you have a diaphragm that it's sitting right on top of the skin, so it's picking up the vibrations of the skin. When you flip it, the bell creates a sound chamber and it picks the low sounding pitch sounds because they are echoed in that small little bell. So the diaphragm, you can hear the S1 and S2 and a lot of the murmurs. This bell, it's usually for S3 and S4. We talked about the maneuvers to amplify sound. Left lateral decubitus for mitral stenosis in S3. Lean in forward for aortic regurgitation. Respiration, inspiration increases the right-sided sounds. Expiration increases the left-sided sounds. How does that sound? It sounds like something you can follow up with, correct? Now, when it comes to murmurs, I don't know about you, you're probably smarter, but I will tell you that when I was in your shoes, unfortunately, it just killed me. I couldn't understand. People were getting it, and I'm not hearing it. I don't know what you guys are hearing. I don't know. Where is this sound? How does this sound look? How does this sound feel? And that just bothered me. I felt like I was stupid, honestly. So what I learned is that's because we are doctors and we ask so much of ourselves. We want to learn it all at the same time. Don't do that. Learn one murmur at a time. This says one murmur a day. I did one murmur a week. And if I find a murmur, I go back every day and listen to it and do maneuvers and listen to it again. Use another stethoscope just so that I make it my project. It's going to be something I'm going to learn. So some people say, why am I going to do that in order for me to, when we have an echocardiogram that's going to give me the diagnosis? It's not about, I know there's a murmur, so I'm going to diagnose it with I don't know that there is anything. I'm examining my patient for the first time. And if I don't know what murmurs are, I'm going to hear something and I'm going to think it's fine. But when I've heard a murmur before, I'm going to hear and say, wait, that's a murmur. Let's call for an echocardiogram. Okay? Does this make sense, everybody? Yes? Thumbs up? Maybe? Questions? Very nice. Thank you. All right. Now, there's not much that is left for us. I'm going to start you, but we're not going to do it today, the ECG mapping to the anatomy. What does that mean? It means that when we're talking about the ECG, every electrode has an axis going to it, an axis of electricity. And so wherever that electrode is, that's the tip of the arrow coming from the heart. Okay, so what that means that the electricity going through that arrow from one place to the other, I'm going to look at how the QRS looks in there, and I'm going to see if there's anything abnormal. For example, if V1 and V2 are right here, the yellow and the turquoise blue, that means if V1 and V2 has a heart attack on them, the heart attack is in the septal area. Then I have to go back to the anatomy of the heart and say, what is the artery that feeds the septum? It's the left anterior descending artery, the LAD. So I'm looking at an EKG and I can already determine which artery might have the heart attack. Does this make sense, you guys? For example, if you find this right here, this is V1, but then you find in others like AVL, the left hand, AVF, the foot. If I have it in V1, AVL, and AVF, that's where the heart attack is, guess what? It's going to be in the right heart. And the right heart is fed by the right coronary artery. So the heart attack is in the territory of the right coronary artery. And that's how we use the EKG to map out where the problem is on the surface anatomy of the heart. Does this make sense? Fantastic. We are going to have a session for ECG, but I wanted to get you excited about it. So in 60 seconds, how can you do a proper cardiovascular examination? Well, at first, you talk to your patient. And while you're talking to the patient, you look at the other vessels, not just the heart. You see at the bottom of their neck are the carotids doing this. Okay? So if the carotids show that there is a if the carotids show that there is a right there. So when you look at the carotid, what you saw was the auscultation was done by the bell. It does not get done with the diaphragm because you want to hear if there is a bruit, if you hear a whooshing sound. And what I mean by that is there might be a cholesterol plaque and the fluid going there becomes turbulent. But before you put the stethoscope, you also want to see how the carotid throbs. So we're going to take a look at his carotid before he puts the stethoscope on. Let's take a look. And it looks quiet. Sometimes it is not quiet. Sometimes the carotid is throbbing. And if it is throbbing, it means many, many things. It could be because there is an aortic regurgitation. So the aortic valve is open. And so you're sending a huge cardiac output because some of that regurgitates each time. And now the heart has to pump even more. And so there is a jet that comes out in the aorta, and the jet goes to the carotids, and you can see the carotids constantly booming. That is important for you to make sure that you inspect before you auscultate. Then inspect the precordium. Is the precordium lifting off? And you inspect the jugular venous pressure. Are the jugulars completely engorged? If the jugular venous pressure is high, then that means there is some degree of heart failure. Okay, so let's see first how it looks like. We are going to show this is how a jugular venous pulse and pressure is. Okay, agreed? Yes? I'm waiting for reactions. Thank you, Muhammad. Okay. So usually the jugular venous pulse goes maybe halfway, about 5 centimeters, but here it goes all the way. So how do we measure that? Well, here's the internal jugular behind the sternocleidomastoid, right? So to measure the pulse is where you lay the person on the head of the bed elevation at an angle. You turn their head to the left. You unclear this area. You look for the sternocleidomastoid right here and the clavicular head. Those two give you a triangle. You have the clavicle right here, and the interior jugular comes out of here. If it's small, then that's normal. But if it's long and engorged, like so, this is not normal. It's an increased jugular venous pressure, right?
Excuse me,
So,
doctor.
yes.
We can measure the external jugular vein instead of internal, because the internal jugular is behind the sternocleidomastoid muscle, and it's will be the same pressure in both veins. Is that okay?
So when we were talking last week, we said you can use blood pressure, or you can use temperature using your hand, or you can use the blood pressure without stethoscope, but only if you do not have the resources to use it the right way. But when you can use it the right way, you must use it the right way. What you need is the internal jugular, not the external jugular. In the absence of the internal jugular, you can look at the external jugular. Why is that? Your mind tells you, well, it's the same and they're parallel and they emanate from the same place. And if one is pressured, the other one is pressured too. That's what you're thinking, I'm sure, because that's how I was thinking. But the problem with it, Muhammad, is which one is extensively studied, validated, false positives, false negatives, sensitivity, specificity across which kind of positioning and in what kind of indications? The internal jugular. So when you use the external jugular, you're saying it's probably okay, but I have little evidence to validate that. I'm just making a speculation. That's my answer to you. Does that make sense?
Okay, okay, doctor. All good. Thank you.
When we are in cardiology, for example, امبارح كنت باخد بالي من واحد من العيانين والدقات القلب they were in the 120s 130s for the entire morning. فاجت لعنده and قلت لهم I am going to start him on carvedilol. And the nurse said to me, somebody else already started him on metoprolol. يعني واحد فينا بيقول ايه metoprolol, carvedilol, كله واحدة, no? I mean, both of them are cardioselective, both of them are same class, both of them are beta blockers, right? But what I answered is carvedilol has been used in clinical trials over tens of thousands of people each trial, much, much, much more than atenolol in this indication. So whatever conclusions I'm going to make, I would like to derive them directly from evidence and not make an assumption. Make sense? So you position somebody at 45 degrees, and in that somebody at 45 degrees, you look for, this is the sternocleidomastoid. You look at the internal jugular, and then you see where is the right atrium. The right atrium is usually right below the sternum at that point. So you draw a line, usually 5 centimeters from that line at this angle, and then you measure how much is the jugular venous pulse. And the jugular venous pulse here, what is seen is 3 centimeters. So you add the 5 centimeters from the sternum to the heart, and that means it's 8 centimeters. When you are reporting in the wards, I usually say the JVP is at 3 centimeters from the sternal angle or at 8 centimeters from the right atrium. You have to say what that number is from. Is it just the top, or did you add up the 5 as well? And that's how you do the jugular venous pulse. Any questions? Okay, so can you tell me, is this 4 centimeters from the sternal angle or 4 centimeters from the right atrium?
So from the sternal angle.
From the sternal angle, which means the person who listens to you still has to add 5, which is 9. Do you think 9 is normal?
No, I think it's the maximum normal value. It's about 8.5.
Okay, so you are partially correct. It's about 9 to 10. However, when you are looking at the jugular venous pulse, you also want to put it in a context. What if this person is dehydrated? Suddenly you're going to give them fluid and it's going to take it to 12, 13, 14. So you have to make sure that you put it in context. Or what if this person is already on a ventilator and the ventilator has a PEEP of 5 centimeters of water, which means that you have already the heart squeezed by that ventilator. So once he gets extubated, it's going to drop further. And in fact, it's going to drop to nothing. So he may be actually intravascularly depleted. على أي, we don't need to go over it right now. I wanted you to understand that we don't treat numbers. We need numbers in a context. How are our patients in that context? Okay, well, we're coming close to the end of our session for today. So we will finish our slides. We said the 30-second exam, you inspect the precordium and the JVP in 10 seconds. You palpate the apex, where's the beat, in 10, 20 seconds. And then you do the APTM auscultation in 20 to 60 seconds. And here you are. If you cannot hear, state heart sounds 1 and 2 present with normal character. No murmur appreciated. Honest reporting is better than guessing. All right? So what we discussed today, we discussed a way to go through it methodically, how you approach the patient so that you're not nervous, announce what you're doing, check with them, and if you are nervous, say to them they're nervous. People connect with humans. They don't connect with people that pretend to be strong when they're not, because people can see through that. Verbalize. Now I'll check the blood pressure. Now I'm checking the time management. Keep the auscultation at the core. Do not let go of your palpation. Do not let go of the inspection. both of the jugular and of the point of maximal index. Remain professional. Always introduce yourself. If you are a student, say that you are a student. Ask permission. People just want to be helped. They just want to feel like they matter. Smile naturally because the confidence trumps the arrogance. And what's the difference between confidence and arrogance? It's that humility. احنا بالعرب we confuse humility with modesty. ونقول لا انا متواضع منك تقول لي should be يعني no انا متواضع. تواضع انه you don't have anything, and that's modesty. Humility is to be transparent about who you are. If you're scared, say you're scared. If you're vulnerable, say you're vulnerable. Announce it. Don't wait or pretend that you're otherwise. You position the patient actively, meaning that position will change, and offer help. Whenever they're about to move, small things. People pay attention to the details when they're afraid. If you just put their hand behind their shoulder as they're leaning forward, even if you did not necessarily lift them, they just notice that you are helpful. If you ask them, I touch you here, they know you're somebody who cares about them. And then the commitment is surface anatomy is your physical diagnostic map. Building skills incrementally, one landmark, one patient, one murmur at a time. And in low resource setting, your physical exam is everything because you have nothing else to study your patient with. So find the apex in 3 patients this week. That's how you should go. Commit to one practical skill today. And I am available. الساعة 5:20 دقيقة. So I know some people had to leave, but I'm glad to those who stayed, and I will post this as soon as we are done, and we will be having some fun examinations in during the week on the WhatsApp group. Qusay, marhaba, I just saw that you joined. Thank you, Muhammad. Thank you, Duha. كيف رمضان معكم؟ طيب، الله يتموا بالغفران. الله يتموا بالغفران. الله يرحم شهداء المسلمين والله يعينكم. ولو في سؤال أنا رهن الإشارة. The only thing I will say is there was a session scheduled exceptionally for tomorrow morning. That session has canceled. The person has a child and the child is not doing well. We have a flu that is sweeping the United States, but because of our current circumstances we don't hear about it in the news. بس لا زي ما بتسمعوا أن الأسبوع اللي فات كنت كله بالفراش يعني I was not doing well at all. بس الحمد لله شوي بشوي. So he was not able to keep it, so we will postpone it for next month inshallah. Okay? الله يحفظك قصي. I'm here. I'm available. لو في أي احتياج أنا رهن الإشارة. I will contact you on WhatsApp قصي من شان طلبة السنة الثالثة. أديك الاسم تبع الطالب اللي حكيت معه اللي كان حيحكي مع رفاقه, and then we can follow up on that. وسلم لي على الأخت آية وعلى الجميع. يعافيكم. يلا تقبل الله صيامكم. السلام عليكم.